So I think we'll get started because it's a little bit
Okay.
after 7 and possibly more people will join us. But
Okay.
we're the Adult Education Committee that comes up with ideas for the Mavens programs. Thought it was time to hear from our infectious disease expert, Dr. Schwimmer, again. We
Mhm.
feel so lucky to have you in our midst to kind of interpret what's going on in the world for us.
Okay.
We read all kinds of stuff in the newspaper and, maybe some of us go online looking at CDC reports, but it can be very confusing and seemingly contradictory. And, sometimes we just don't know what to think. So we have a Maven, we have an expert in our midst, and we want to hear from you tonight. I do want to say to those gathered here that this is not a conversation about policies at the temple. This is for us to learn about what is going on with COVID nationally, internationally, what are best practices, what should we be concerned about now? And yes, Dorothy, thank you for taking off your blinking screen. I don't know what that, I can't even have seen anything like that before, but we'll
Yep.
just know you're there. And we'll turn it over to Dr. Schwimmer. Thank you for being here. So
Okay.
you want to say a couple introductory remarks, and then we said it was Q&A. So, basically what people want to know.
Okay. Well, a reasonable early estimate is over 260,000 deaths in the United States from COVID in 2022. This is using the same definitions and criteria that have been used in the previous years. The number will change. This is preliminary, but it's a reasonable indication. Makes it the third biggest cause of death in the United States. The ones ahead are heart disease and cancer. All cancers collectively put together, all of which are in the 600,000 range. Number 4 are unintentional deaths, including overdoses, which is over 100,000 deaths in a year, and continues to rise. So we have yet another strain. It's called XBB, I think 1.5, which is rapidly spreading in the United States, and it is susceptible by one of the types of immunity that we measure, which is called neutralizing antibodies, especially with the bivalent booster, for which maybe 45 million people in the United States out of a population of 330 million have actually received, and has the relatively original Omicron strain from a year ago. We have what's happening in China. China has completely abandoned. They've basically gone from one extreme to another. They stopped reporting. There are some reports which are reasonable, that in December, in part of December, they had about 250 million cases, and upwards of 25% of people on flights coming in from China are testing positive. We don't know about what the strains are because China's not reporting that anymore. They've been doing basically wastewater samples on the airplane, from stuff in the airplane toilets, and they're looking at strains there. But China is definitely exporting COVID right now. Okay. What else?
Steve, could you
So,
just go back and clarify? I guess this will be the first question. One
Sure.
thing that you said, the current bivalent booster,
yeah,
which I have had, is
right.
it effective against this new strain, or don't we know?
Um, the data we have, because the strain is really, well, it, was first detected like 2 months ago at all. The surveillance for strains in the United States is ongoing. I don't know if they still have the sensitivity or not, but at one point, the people were confident that they could pick up a new strain at 1 in 80,000 cases. It's probably one in at least several thousand where it first shows up. There are strains that don't get reported that really don't establish themselves. The data so far is that the vaccines, people who got the first booster, and then people who got the bivalent or who got a second booster with the original vaccine are still have high levels of protection with the XBB strain against hospitalization and death. It is incredibly transmissible. The transmission rate, what's called the rho sub O, which is the average number of people who can be infected by one patient who has it, is 16 people.
Wow.
It's phenomenal. And these things, of course, are a moving target. There were a couple of strains of XBB before the current one, and one of them had a set of mutations in the spike protein, but it's binding to the ACE inhibitor, the ACE receptor, which is where the virus mainly binds to infect cells, was decreased. Then that mutated to a stronger than previous binding to the ACE receptor. So the latest strain, the one that's rising rapidly throughout the United States, is one that binds closely to the ACE receptor, which makes it easier to establish an infection, and has the mutations which have it evade that part of immunity called neutralizing antibodies. But there are other types of immunity that the body has, most of which fall under what is called cellular immunity, and this seems to be maintained and be more broadly effective. That's why people will get infected and have illnesses, but be less likely to get sick, be hospitalized, or die.
Wow. Okay, does someone else have a
Some people are-
question for Steve?
I do.
Okay, Kathy.
Yes,
So those of us that have received the initial 2 vaccines and then the 2 boosters and then the bivalent one this past October, when are we due to have our next booster?
as of now, you've got everything that's available. We don't know. There's some work in the direction of combining COVID vaccine with a flu vaccine with a view toward having an annual vaccination in the fall. But that vaccine has, as far as I know, has not yet entered clinical trials. And the duration of immunity is a really tough question because for a lot of reasons. Number one, we keep getting new strains. And when you have hundreds of millions of people who are having trillions and trillions of virus and with different strains that sometimes meet in the same person or in the same animal, because it's well established in certain animal populations, including white-tailed deer, this allows for the emergence of new strains. And so, that's where things stand.
Okay, Esther?
Yeah, so that's part of the question I was going to ask Steve. So it feels to me like COVID is here to stay the way flu is here to stay. And if I'm wrong, I mean, that's an assumption of my question. So if that's the case,
Okay.
and every year they say, well, they're not sure they got the right flu strain for the vaccine, and I suspect that's going to be the same thing for COVID. So are we going to, in the future, be viewing these two similarly, or is one worse than the other?
COVID kills about 10 times as many people as flu. Okay.
Even those who are vaccinated and
Yeah.
and all the,
And what happens with the flu vaccine is every year in the spring, a group of people who study this all the time have to make a decision based on the strains that are circulating in the Southern Hemisphere, strains that are circulating in people and animals in China, and make make a decision about which specific strains are going to be in the flu vaccine, because you need the lead time. It's probably a few months less than it used to be, when all the virus that was grown for flu vaccine could only be grown in embryonated hen's eggs. And we now have cell culture media that cuts some of the time. But it's a big process. There have been times when the virus has mutated in the process manufacture, and you had some escape there. This year, the match is very good. On average, if you take several years, flu reduces your risk of dying. Flu vaccine reduces your risk of dying from the flu by about 60%. This year, it's probably a higher percentage of protection. The COVID is mutating quicker than flu does. And flu should be taken a lot more seriously than it is. Once at a meeting, one of the presenters said, flu is the Rodney Dangerfield of infectious diseases. It doesn't get any respect. But it's a big deal. And it causes plenty of damage. And it can stress the healthcare system. There have been flu seasons when hospitals I've worked on have been full because of flu.
that's why I was wondering if there was a parallel to COVID, and if these are going to be treated similarly, get a vaccine and it'll reduce the risk.
And there is a medicine for flu. It's called there's a couple of them. One of them is called oseltamivir, which has been around for a while. There's another one that's called Paxlovid something. I really don't remember. They need to be started within 48 to 72 hours of symptom onset for flu. They are, and it's in short supply, and there is a national reserve that has now been tapped because we had an early high flu season with 20 million cases, 13,000 deaths already.
It sounds like that drug is a lot like the Paxlovid that people take for COVID. And so a question about Paxlovid, you can answer that, but I wanted to know if, I know originally Paxlovid was only suggested for people in high risk or older people. Can anyone get Paxlovid now?
I think it's in decent supply these days.
Okay.
That's my understanding. And unfortunately, the monoclonal antibodies, which were effective against previous strains, are not effective against XBB. And so the FDA is probably going to withdraw its approval for it.
But not for Paxlovid.
Not the Paxlovid,
different.
and not remdesivir,
Okay.
which is IV, but can be given as an outpatient and also reduces your chance of hospitalization and mortality.
Somebody else? Another
Is
question?
one of those flu medications that you just named the same as Tamiflu, perhaps a brand name?
Also, Tamivir is the trade name is Tamiflu. I'm persnickety about trying to use the generic names and not the brand names, but they make the generic names difficult. Paxlovid is Nortrevilior, ritonavir, and that's a mouthful.
It's actually two different pills.
Okay, and all right, I think everybody. I'm sorry, I'm literally 2 feet from my wireless modem, but I'm still having problems.
We're catching most of what you're saying.
Okay,
Not a problem.
okay.
Somebody
other-
else, another question?
I have one. So is there
Sure.
a relationship between having COVID, or no, I'm sorry, getting the vaccine and having a stroke? Because you keep hearing people say that that's happened.
Okay, so there was just a report on one of the types of vaccine adverse reporting systems, of which there are several, and which are designed to be very, very sensitive as a signal to be followed up. So on one of these reports, it seemed like there was an increase in strokes in older people. So they went out and they compared to people who got vaccinated in the VA system, people on Medicare who got vaccinated, on a couple of the other vaccine adverse reporting systems. There's several of them. And they checked on other countries where people got the same vaccines, and it's not showing up there. So I'm confident that it was a signal. It's designed to pick up things and then be looked at and see whether it's real or not. Okay.
Other questions?
Okay, I have a question.
For some of that, let's.
Okay,
Okay, there we go. Okay, anybody else got questions?
yep, I do. So
Okay.
this is not so much about going forward with what we're understanding about COVID, but maybe so. Anyway, do you have any information or knowledge on why in a household one person can get COVID and another person doesn't? Well, I mean,
had the
there's just
same
so many
question.
people that we know that, and it seems like a lot of times it's the wife that doesn't get it.
Okay, that's a very tough question. There's several answers to it. Number one is some people don't get COVID as much, or the risk is definitely less. There's a whole long list, which I can show you if you're interested, of conditions that do increase the risk of getting COVID and getting sick and getting severely sick from it. Another aspect is a lot of COVID is genuinely asymptomatic or very, very minimal symptoms. And people are not aware that they have it. That doesn't mean they can't transmit it, especially with the newer variants, which besides evading immunity, are increasingly easier to transmit. Those are the two big things. Frozen again. I'm sorry.
Kathy?
I'm gonna.
Thank you.
So Dr. Schwimmer, what are your recommendations for us going forward as far as should we still wear masks when we leave our house and we're going to be around other people?
I think so. That's what I do. You're wearing a mask right now. I don't know if you're around anybody at this
No,
point.
that's not me. Alice is wearing a mask.
Oh, I see. Okay.
Alice, you're muted.
Oh, I'm sorry. I thought it was Alice.
Alice, but Alice was muted, so we don't know. what she
Okay.
said.
I'm in the Minneapolis airport. I'm wearing. a
That's a good reason to be masked. Very nice. Very nice. Okay. Yeah. And masking is very important. There's something that I'd like to take a minute or so and show you about masks and efficacies. Let's see if I can find it. Okay, I got to share my here. Let's go here. Yep. Now I got to share my screen. Okay. At the beginning of the pandemic, there was a shortage of the surgical masks and respirators. And so they were reserved for healthcare workers for obvious reasons. That is no longer an issue. Even with cloth masks, it depends on the kind of cloth and the seal and everything like that. And also surgical masks, the better the seal, the more efficient they are. But the N95s are available. You can get them at the drugstore. You can order them online. They are a little harder to wear, but it takes practice like everything else. And if you're going to wear a mask, you might as well see about using the most effective type of mask. Okay.
So that looks like it has the two bands, not the ear loops. Is that what you're saying?
It's a question of how tight it is. You can do an ear loop one where you pull it tighter behind and get a better seal. And that helps protect you from somebody else who has COVID and protects from you, increases the protection for you from spreading COVID, especially the latter. But both of them are very significant.
So are you suggesting that, I know I'm going to get a lot of grief on this, but are you suggesting, since you're saying that we should wear masks when we're around other people, when you're in a restaurant and you're eating, you cannot wear a mask? So are you suggesting don't go out to eat?
Yeah, it depends. There's a series of levels of spread in a community for recommendations about mask wearing. It gets fairly confusing fairly quickly. The CDC currently has 3 levels: green, yellow, and orange. Kenosha County is still on their graph reporting at least 4. So for the green, which is the lowest level of community transmission, there is not a recommendation for wearing masks. For yellow, and one of the confusing things is they had to change the criteria that they use to determine the levels last year, because the original criteria, which were number of positive cases per 100,000 and percentage positivity, became unreliable because of all the home testing and a reduction in people getting PCR or getting antigen tests when they were ill. So now it's hospitalizations and a variation on that. One is rate per 100,000. One is a percentage. I have to go back and look. I could find that. For yellow, and this is also a change that was made last year. The CDC is recommending that people who have high risk are at high risk for getting sick and getting sick or seriously ill should mask in general in indoor public spaces. And but that list is very long, and I'd like to show it to you. Give me a minute, and I'll find it. All right. Thank you for your patience as I slog along through these things. Okay, so first of all, okay, it's a long list, and that's a point that I want to make a point of. Okay, first of all, besides medical conditions, there's age, and age over 65, and the majority of deaths from COVID are still in older people, and the older people are, the higher the risk of dying from COVID. So cancers, chronic kidney disease, chronic liver disease, chronic lung disease, cystic fibrosis, dementia or other neurologic conditions, both types of diabetes, various disabilities, people with ADD, I didn't realize that one, that's interesting. Heart conditions, HIV infection, weakened immune system, and we can go to there. And mental health conditions, overweight and obesity, physical inactivity, pregnancy, sickle cell disease or thalassemia, smoking, solid organ, stroke, CB, substance abuse. Okay. Now let me find, do I have it here? No, it must be on another one. Let's see if I can find it. Nope. Okay. All right. This is broken down by the evidence. So this is out of the CDC. This was actually the one I wanted to show you. The other one is for the general public. But this talks about some of the evidence base and breaks it down by conclusive that there's higher risk, asthma, cancer, which covers and the type of evidence involved. A systematic review is where you find relevant studies and classify them in a specified manner and review that as a total evidence. Oh, what happened? Okay, so these are where it's felt to have conclusive evidence: asthma, cancer, cerebral vascular disease, stroke, chronic kidney disease, chronic lung disease, cirrhosis, non-alcoholic fatty liver disease, alcoholic liver disease, autoimmune hepatitis, both types of diabetes, cystic fibrosis, disabilities including Down syndrome, heart conditions, HIV, depression, schizophrenia, neurologic, obesity, physical and pregnancy. And by the way, vaccination not only protects the mom, it protects the baby. Smoking, solid, okay. So, and here's where there is less evidence, sometimes because there's fewer people to look at. Mixed evidence. Okay, so let's see. Oh, no, there we go. Sorry about that. Machine. Okay, I'm back. All right, and okay.
So I think the question that prompted you to show all that was, should we still be wearing masks and not going to restaurants? And when would you recommend it's okay to not wear a mask or go to restaurants? Like, do you do that, Steve? Do you go to restaurants?
I do not go to restaurants. As a matter of fact, I think about even wearing a mask when I do a drive-through. When it's green, I'll go to a restaurant.
Okay.
And if you go back to your comparison to the level of infection in the population among people and compare it to flu. Some of the changes in category from green to yellow to red or orange. The lowest one is less than 10 per 100,000 per week. Flu has been 26 per 100,000 for the entire flu season so far, about 3 months. Okay, so there's a lot of COVID out there again. The fact is that's a very long list, and that's that may be a majority of people who come to the temple.
What about planning a trip to go to another country? Is it okay to be planning a trip?
I'm
Like
sorry, you
for-
broke up. Where?
Is it okay to be planning a trip to go to another country?
I'm sorry.
How do you feel about planning a trip to go to another country, to Israel in the fall?
In the fall will be, it's entirely too early to tell. That's a problem. And I know you got to plan these things.
Trip insurance.
Yeah, that's a good suggestion.
I mean, it just seems like a lot of people are traveling again, and it
Yes,
seems so common that people come back with COVID,
yes, and
or they get it while they're there.
or in the airplane. Especially a long distance plane trip. Some cutoffs are 10-hour flights. I don't know. I forget. Israel is 8-hour time zone. I don't know how. I forgot. How
It's
long
like 12 hours at night if you go nonstop, I think, 11 or 12.
right. And I don't think. Actually, a judge just ruled that the feds are not allowed to mandate masks on airplanes again.
Yeah, I mean, Alice, I'd love to know what percentage of people in the airport do you think are wearing masks? And Minnesota is a pretty, progressive state, so that will be an interesting answer.
Yeah, well,
The majority are not. I want to, as I sit here and see people go by,
mhm.
a third, a quarter of people are
Yeah.
wearing masks. Yeah.
Yep.
And I bet it's even
Yeah.
less in Milwaukee. Mhm.
Okay.
Anything else? Any
Well,
other
I guess I
questions
want
for
to ask Steve, how do you feel about traveling on an airplane, whether it's in the US or out of the country? I don't know if you're comfortable with expressing that, but I'm curious.
I'm real uncomfortable about it. This summer, when transmission was low, I did take a trip to Argentina, and I probably got COVID on the flight back. I wasn't very sick, and I got on Paxlovid. And I wore a mask as best I could the entire flight. It was a long trip. I'm trying to do bucket list things, and I figured I might as well give it a shot. But and the situation now is much, much worse.
What worries me is and even once you get there, obviously you're not at home, so you can't be eating at home. You have to go into a restaurant setting to eat, which means no masks.
Yeah, that's a legitimate concern. I have no idea what it's going to be like in the fall. Israel, as you know, has been very, very aggressive and successful as far as convincing a large majority of the population to get vaccinated. As a result, they've done a lot better than the United States. Yeah.
Esther?
Can you project into the future? Probably not, but I'm just wondering if this is the way life will be now for eternity? Or is this a 2-3 year, horizon out there until we?
Well, if you go back, real far back, there's a history of pathogens that attack, that show up for the first time, and over time they become less deadly. But sometimes it takes generations.
Yeah, I was saying to you, go ahead. Esther.
I'm just saying, I'm running out of years to get my bucket list taken care
Yeah.
of.
I'm in the same boat. I'm 68.
Add 10 to that.
Just quickly before Dorothy, you'll be next, but Steve and I were talking earlier, and I mentioned this article in the New York Times yesterday, I think, or maybe today, that said that the peak, the spike that happened last year at this time was dramatic, and the one this year, it appears it's not nearly as bad, and it is already maybe going down. And so can we hang on to some hope that maybe we'll go back to green sometime soon, or is it just impossible to tell?
The history has been that there's been a spike in the winter. It may be, this is opinion of mine, on my interpretation of some of the evidence. And it shouldn't be taken as much more, anything more than that. That one of the reasons why it's likely that we won't have the spike like we did a year ago is because we had the spike a year ago, and so many people became infected that that people have at least that kind of immunity, which is real, but it may be as low as 30-40%, depending on when you were exposed, how long it's been, and what strain you were exposed to, and what strain you're exposed to now. But most of the people in the country have had the initial 2 shots. A distressingly small percentage have had the latest booster, especially the people who are at higher risk, including old farts like me. And each of these modalities it acts independent of the other. The vaccines, are one thing, the masks are another. Getting tested and isolating, if you get sick and find you have COVID, is another, which is underemphasized in my opinion. And by the way, through the state, you can get free telehealth evaluation for COVID on the Department of Health Services COVID website. There's a link. If there's no other way to do it, that's available. And social distancing. Sometimes you can do some of the, sometimes you can't do them all, but still, they all are effective. And one of the, in my opinion, underappreciated benefits of wearing a mask when you go out in public is you're reassuring other people who are out wearing masks, even when we're a minority. Sometimes they call these network effects, but it makes a real difference, setting an example.
Dorothy, I think you were next.
My question was, I'm just getting over COVID, Steve.
Yep.
And and you kind of alluded to my question on your previous talk, but I want to know, have I built up any immunity towards it, or the chance that I would get it again?
Okay. If you just had COVID, it depends on which strain you have. You're still at risk of getting it again. It's a decreased risk. You almost certainly had one of the Omicron strains. Whether you had the XBB is at this point for Wisconsin, less likely, although it's spiking rapidly. Yeah, you need to continue all the precautions.
Thank you. It drove me crazy last week trying to figure out where I even picked up COVID, because I keep my network to the same people for the last 3 years. And then finally my daughter said, doesn't matter, you got it, Mom. So I don't even know where because I wear a mask when I go to the grocery store. I wear a mask most of the time, except if I go to a restaurant, of course, I take it off to eat. So I will be same cautionary procedure I've been doing right along. But thank goodness I got that Paxlovid, and I was not, and I'm doing good. I'm ready to go.
Glad to hear it. A couple of things, my opinion, which I think is based on the data, and especially since I don't, we're likely have not seen a peak yet, is to avoid restaurants. And you could look into, if you're not using an N95, go get an N95 and practice using it.
I use an N95.
Good.
I've used N95 from the beginning.
Good. Okay.
Steve, what do you mean by practice using it?
It takes practice. If you go out and you see people wearing masks, not everybody puts it over the nose and mouth. And like I say, even, not with the N95s, with the other two, how you have the mask set up and how tight it is. Ideally, you don't have an opening on the sides. There's a complete, sealing off of the nose and mouth. Okay. And that takes some practice. And people pull on it and stuff like that. I mean, that it's not a natural thing.
Any other questions for Dr. Schwimmer?
Had any questions?
Alice?
Said something earlier.
Oh, you
that I
froze.
wanna make sure-
Yeah.
You said something earlier. I want to make sure I understood. You said you'd be more likely to go out to eat if it was raining. Did I hear you say that?
No,
Did
I said if it was green, it was the green level, the low
Oh,
level.
green. I was going to say there's something
sorry.
there I missed.
Okay,
And yes,
yeah,
there was.
what we have here is a failure to communicate.
Okay.
Some people know that movie.
All right, well, this was really helpful, Steve. I know all of us have questions all the time about
Okay,
this stuff.
happy
and
to be of
we're just-
assistance.
Thank you so much.
All
And,
right.
I do want to say to people, if you did have a question about how we're handling things at the temple, Mimi Snyderman Platt is now the chair of our COVID committee, and we have, I think, 5 medical professionals, or some of them are retired medical professionals on the committee, plus others. So feel free to contact her. And, that committee is considering questions that come up and looking, always looking at what we're doing and reevaluating. So have a good evening, everybody. And Steve, are you okay if I save this to our YouTube channel? And
Oh,
people
sure,
can
sure.
back and look at it?
I was surprised when I found out that my last lecture was on YouTube.
Well,
so
we'd like to put this one
I'm a
there.
YouTube influencer now.
Yes, absolutely.